So in the IVF, we already do a basic little of filtering, which means even if we have 15 eggs, we'll probably end up with 4-5 blasts. Now our negative predictive value is very high, so we say we know that the other 10 eggs in trying to figure out whether these embryos that we've got in IVF are chromosomally normal or not is what is known as PGT-A or PGT aneuploidy. Simply because we want to be very, very sure that the baby so born would not be chromosomally abnormal. So again, the bottom line that I'm trying to say is not every IVF needs to be a PGT-A. Hi everyone, you're watching Fertility Fridays with me, Dr. Shweta Goswami, where we try to welcome hope into your lives. Today we'll be talking about a topic concerning IVF, which is genetic testing in IVF. So it's a question whether we do it or not, but everybody does ask us that how important is it for me to do it? I'm very worried that the baby should not be born abnormal. So what can I do about it? So I thought I'll make a short video about it. So first of all, in scientific terms, this technology is called PGT. It used to be called PGS earlier. It's called pre-implantation genetic technology, PGT. And there are three types of PGT. There is a PGT-A, there's a PGT-SR, and there's a PGT-M. Now, the most commonly done pre-implantation genetic testing is called PGT-A, which is A is for aneuploidy. SR is for structural translocation, structural rearrangements, and M is for any monogenic disorders. So broadly, when we need to understand is that when we talk genetics, we are loosely using the word genes, but we are actually talking about the fact that are the chromosomes affected or are the genes affected. So broadly, we should just understand this, that अगर जैसे किसी lady की age बढ़ती है, so especially when we are above 36, or we've had recurrent miscarriages, or we've had unfortunately recurrent implantation failures, which means IVFs have not worked out, we say our big question mark is that whether even very good grade A blasts, which are looking excellent, are they actually healthy or not? And the reason for most IVFs not to work, or somebody to undergo miscarriage, unfortunately, or if it's an age-related fertility decline, is that not every egg and embryo is healthy. So in the IVF, we already do a basic little of filtering, which means even if we have 15 eggs, we'll probably end up with 4-5 blasts. Now, our negative predictive value is very high. So we say we know that the other 10 eggs and embryos are not going to give us a healthy pregnancy. There's no point pursuing them. But out of these 4 to 5 embryos also, each embryo has only a 35% implantation rate, which means only 1 in 3 or at best 50% of these embryos are going to be chromosomally normal. So the word is chromosome, and we need to understand that when the eggs form, 46 chromosome breaks into 23 and 23. A lot of times due to non-disjunction, this division is unequal, resulting in eggs and embryos which are unequal in chromosome number. Trying to figure out whether these embryos that we've got in IVF are chromosomally normal or not is what is known as PGT-A or PGT aneuploidy, right? So that is something that is most commonly done. As I said, the main indication is if somebody is above 36, 37, if somebody has recurrent miscarriages, if somebody has recurrent implantation failure, somebody has had a previous history of Down syndrome or any abnormality, somebody has had a prior personal or family history of somebody having a chromosomal abnormality. So when the parental karyotype, which means the husband and wife's karyotypes are normal, this PGT is called PGT-A, right? Then coming on to the next one, we call it PGT-SR. Now that is only specifically done for couples where when the karyotype was done, either of the couple has what we call balanced translocation, which means they have either reciprocal or what we call Robertsonian translocation. They have basically an abnormal karyotype report in the couple, one of the parents, and therefore we have to do embryo selection. When we do the IVF, we get to the blastocyst stage, then we do PGT-SR to figure out in a couple with an abnormal karyotype report, which is honestly very rare. It's less than 1% of people. Then in that case, the PGT-SR will help to identify which embryos are normal. They do not have the chromosomal complement that they have to inherit from either the father or the mother, and therefore that PGT is done. It's extremely helpful in patients who unfortunately the usual diagnosis is made when they've had repetitive pregnancy losses, recurrent miscarriages. Then one of them comes out with a structural rearrangement, and then because of these translocations, IVF with PGT-SR is planned. The third PGT that we call is PGT-M. So to give an example, suppose both the husband and wife come out with a genetic disease. So there has to be a genetic problem here, not chromosomal. And they have, say, both are carriers for thalassemia. They're both otherwise normal. But if they plan, they unfortunately have a 25% chance of the baby having thalassemia. Similarly, sometimes people do these tests when they realize that unfortunately one of their child is having a problem, or somebody in their family like a real brother or sister has a problem. So when we get to know that in the family or in that particular couple there is a particular tendency for a genetic issue to come up and the babies so born may be abnormal. So either you can check for that in pregnancy, but that means the woman will have to undergo a miscarriage, unfortunately, at a later stage of pregnancy, or therefore sometimes we do a PGT-M. So here this is a much more technologically or scientifically advanced technique, because you have to actually look for that particular genetic disorder. So you're like really going in depth to check whether it is there. Then the embryos that have an abnormal genetic component are discarded and the normal ones are done. And therefore we say that, okay, the technology has been of huge help in preventing an illness for the patient. So broadly, I'll just sum up. There are 3 types of pre-implantation genetic testing. PGT-A, which is most common. It is most common because it's done in women with advanced disease or recurrent miscarriage with no common reason, recurrent implantation failures or some prior history, they do PGT-A. If there is a karyotypic abnormality in the couple, they have a translocation, we do PGT-SR. In case there is a genetic issue which we have to make sure that does not go into our child, we do a PGT-M. So broadly, these are the 3 things. IVF level, it's going to be the same. You have to go through injections, get the eggs out, make the best embryos, test them. But the testing in the lab will be very different. So please discuss it with your doctor whether or not you even need it. And on one last note, PGT-A is something which is a part of an IVF treatment, but again, it's not a universal testing. We say you don't have to be worried so much unless there's a strong family history or personal history to suggest so, because usually either these embryos won't implant or they'll undergo a miscarriage. So it's rare for somebody to want to do it simply because we want to be very, very sure that the baby so born would not be chromosomally abnormal. So again, the bottom line that I'm trying to say is not every IVF needs to be a PGT-A. We could do a conventional IVF for most and not spend so much of money on the PGT-A testing. All these tests are specific tests, must be discussed, does not have to be done for everybody because they're also not foolproof sciences yet. They're still in their infancy. There's a lot that we need to learn about this technology. However, for a particular subset of patients, it's an extremely important technology which comes at hand, but not for everybody. I hope you found that useful. For any other questions, please feel free to write in the comment section and or reach out to us and we'll be more than happy to answer your queries. Thank you. So we'll take some questions sent by the users one by one. आपके भी कोई भी questions हो तो please feel free to write in the comment section. I'd be more than happy to reply and get back. So some questions are, ma'am, I'm 14 weeks pregnant. अभी FTS test कर सकते हैं क्या ma'am? Which is called first trimester screening. Please help. So देखिए एक्चुअली एकदम ही ये एल्गोरिदम और सॉफ्टवेयर बेस्ड होता है 13 वीक 6 डेज के बियॉन्ड, एंड इफ यू आर श्योर कि आपका प्रेगनेंसी का टाइम भी उतना ही है तो उसमें FTS टेस्ट अब नहीं हो सकता. तो हमारे को अब नेक्स्ट बेस्ट जो टेस्ट होता है क्वाड्रुपल मार्कर होता है. तो एक तो NTN भी आपका हाई होप हो चुका है तो वो एक एक्यूरेसी हमें बता देगा, प्लस हम क्वाड्रुपल मार्कर एक 16 to 18 वीक्स पे करेंगे. दिस इज द बेस्ट टेस्ट जो हम कर पाएंगे. बट अगर आप यंग हैं, कोई और मेजर इंडिकेशन फैक्टर नहीं है तो आई थिंक दैट शुड बी फाइन. Lovely कह रही है, मैम माई TSH is 9. माई गायनाक had suggested me 75 milligram thyroxine. Will I have to pop this medicine for rest of my life? So actually ये एक प्रीवियस वीडियो में भी मैंने बहुत क्लियरली बताया भी था, क्योंकि सबके लिए, आपका ही नहीं सबका एक कॉमनली आस्क्ड क्वेश्चन होता है और हम क्लियरली ये कहते हैं कि जिसको हम सब क्लिनिकल हाइपोथायरॉयडिज्म कहते हैं, T3 T4 नॉर्मल है, TSH थोड़ा हाई है, ये फ्लक्चुएट भी कर सकता है, कभी ऊपर नीचे भी जाएगा, तो ऐसा बिल्कुल भी नहीं है दैट यू नीडेड लाइफ लॉन्ग. देखिए TSH थोड़ा 8-9 अभी हाई है, तो फर्टिलिटी पॉइंट ऑफ व्यू से तो हमें 100% ये लेना है. एज वी प्रोग्रेस ऑन वी विल कीप चेकिंग. अगर डोज कम भी होना होगा तो करेंगे, और डिलीवरी के बाद इनफैक्ट हम बंद भी कर सकते हैं, या 6 वीक्स के बाद दोबारा जरूर चेक करना चाहिए हमें 1.5-2 महीना डिलीवरी के बाद. अगर उस टाइम पे TSH लेवल्स बॉर्डरलाइन हाई भी होते हैं तो उनको इग्नोर कर दिया जाता है. बट अभी ये फर्टिलिटी एंड प्रेगनेंसी के पीरियड में प्लीज लीजिए, जरूर इंपॉर्टेंट है. ये बिल्कुल भी लाइफ लॉन्ग दवाई शुरू नहीं हो गई है. एक और यूजर कह रहे हैं, हेलो माय वाइफ डिड NT&B स्कैन एंड इट इज CRL is 68 एंड वैल्यू इज 2.9, वो मोर देन 95th परसेंटाइल तो है। तो देखिए हमारे को अगेन वही चीज, एक अच्छा NT&B ये किसने किया है, वो NT&B स्पेशलिस्ट हैं कि नहीं है, पहली चीज ये है। प्लस हमें बाकी फैक्टर्स देखने हैं, वाइफ की एज क्या है, प्रीवियस हिस्ट्री क्या है, प्लस हमें डबल या पेंटा मार्कर टेस्ट करना चाहिए, और उसको हम कहते हैं कंबाइंड स्क्रीनिंग। तो अकेले NT&B का कोई रोल नहीं है। मान लीजिए NT&B थिक दिख रहा है बट हमारे डबल पेंटा मार्कर ठीक है, तो हम उसको छोड़ सकते हैं। हमें बहुत कुछ ज्यादा रिस्क लगे, वी मे इवन हैव टू डू टेस्ट लाइक NIPT और amniocentesis. So all these tests, whether it is the first trimester screening test or NT&B or screening test, we may need to do a confirmatory test to be sure that the baby is healthy. Now another user says, taking painkiller due to fever after 8 days of IVF is okay. So see, until unless it's not done in too severe amounts, in mild doses, paracetamol is said to be one of the safest painkillers in case you're pregnant. So we say that do that, and first always try home remedies. So if you think that other medications using hot water bags etc. helps, great. But if it's don't torture yourself thinking I won't take a medication, take a paracetamol. 1 or 2 tablets would not usually harm. Another user is saying, Doc, you mentioned no nuts. I've been eating nuts because it's high in omega-3 fatty acid to support my uterus. Please let me know if I should stop the nut immediately. I'm in 2 weeks wait. Right, so beautiful soul. See, the thing is that we say that some of these things are warm in consistency. They may have a little abortifacient effect. So it's actually more relevant during pregnancy. And the data and the evidence is limited out there that which nuts are actually safe, which are not. They are rich in omega-3 fatty acids, but we say because they are warm in consistency, they may be inducing some bleeding, spotting. We typically say that except for almonds, if we can keep the other nuts, in moderation. So moderation doesn't harm, but don't take excess of any nuts. Just trying to increase the omega-3 fatty acids at this stage would be my advice. Okay, thank you. So thank you for all your questions. I repeat, like if you have any other questions, please feel free to mention in the comment section. Thank you very much.